It's an honor for me to introduce Dr. Mark Petrie. He's a professor of cardiology, University of Glasgow, honorary consultant cardiologist, Glasgow Royal Infirmary. He's going to speak about an informative talk, Emerging Drugs and Devices in Heart Failure. Dr. Mark?
Yes, so thank you for the honor of speaking to you all in Egypt. I have to say I came to Cardio Egypt a few years ago and had a fantastic time visiting your wonderful country. And there's only one thing I like better than Egypt, and that's Egyptians. We have the honor of working with many Egyptians on a daily basis around the world. And indeed, my cardiology department is led by Hani Atiba, who is one of my mentors and is a fantastic cardiologist and Egyptian. So for the next 15 minutes, I'm going to talk about emerging new drug and device therapies in heart failure. So I'm going to go straight for some very interesting new devices that are emerging. This is a device which is an interatrial septal device, which is very interesting. The aim of an interatrial septal device is to deal with one of the very common findings in heart failure with preserved ejection fraction, and that's high left atrial pressure. So the aim of this device is to establish a communication between the left and right atrium, so between the high pressure left atrium and the low pressure right atrium, and thereby relieving pulmonary edema. So this is a really fantastic trial which is well underway and has completed recruitment and which will report in 2021. So we don't have long to wait for the results of this trial. For a device trial, it's quite large, 608 patients, and they qualify on the basis of an elevated end-terminal proBNP and also an elevated pulmonary artery wedge pressure on supine ergometry. So they do have to go to the cath lab and have a right heart cath in place and exercise. We're very proud of the design of this trial. It's a blinded, sham-controlled trial, and blinded not just from a patient perspective, but also from an investigator perspective. The primary outcome is a hierarchical primary outcome of clinically relevant outcomes, including cardiovascular death, stroke, heart failure events, and quality of life. So I think this is really exciting and is coming our way to present next year. And I really hope that device therapy will help people with preserved ejection fraction as well as reduced ejection fraction. So that's not the only interatrial septal device trial which is ongoing. The last one, the Korva device, is a heart failure with preserved ejection fraction device. This is one where the trial is enrolling people with both heart failure with preserved ejection fraction and with reduced ejection fraction. This is a very similar device, just to create an interatrial septal device again. But the patient population is slightly different. They're sicker patients with more people in NYHA 3 and 4, higher end-terminal proBNPs, or recent hospitalizations. So a sicker population. The trial's blinded, but only from a patient perspective, not from an investigator perspective. And a very similar primary outcome of death, heart failure, hospitalizations, 6-minute walk test this time, and also transplantation or LVAD implantation. And again, this will be presenting in 2022. This is something which I think is revolutionary. So subcutaneous fusimide has been talked about for many years, but there have been major developments in this recently. And there's now a drug-device combination, which is extremely interesting and exciting. The drug combination of fusimide is very concentrated and pH neutral, so very concentrated and skin friendly. And 80 milligrams fits in a 3 ml little cartridge. And the device delivery system is a repurposed insulin syringe. So we're just starting a trial in the UK at the moment where we're randomizing people who are hospitalized with congestion and heart failure to going home with one of these small devices on their abdomen or staying in hospital on intravenous diuretic therapy. So this could really revolutionize the administration of fusimide, allowing it to be delivered subcutaneously through a small pump, rather than people staying in hospital for weeks on end with intravenous diuretic therapy. So I wanted to then turn my attention to catheter ablation for atrial fibrillation. And again, this is a difficult area because obviously atrial fibrillation can sometimes cause heart failure, or atrial fibrillation can exacerbate heart failure. And quite often we're not entirely sure which is the chicken and which is the egg, so which comes first. But certainly it's become easier to do catheter ablation and quicker with development of things like cryoablation. So really exciting times for the role of catheter ablation for AF in heart failure. You'll be aware of the Castle AF trial, which was published in the New England Journal 2 years ago. And this looked amazing. So in a very small trial of 363 patients with ejection fractions less than 35% with AF, randomized to ablation or medical therapy, we saw really quite remarkable improvements in outcome, with reductions in all-cause mortality or heart failure hospitalizations of 38%, amazingly all-cause mortality of 47% and 44% reduction in heart failure hospitalizations. It's a small trial showing really major potential benefits. But many people have looked at this trial saying it's really too small to change practice. And there's also several problems with the trial. Many patients are lost to follow-up. There's many crossovers and things like baseline imbalances. And we could talk for quite a long time about the various issues with this trial. So what's coming next? I think most of us do think there's some benefit of catheter ablation for AF and heart failure. So there are more trials which we're waiting for. One is a Canadian trial, which is going to present very soon at the American Heart Association next year. This is a slightly bigger trial of 411 patients. Again, this time heart failure with reduced and preserved ejection fraction with an endpoint of all-cause mortality or heart failure hospitalization. In the UK, we're starting a trial called CRAFT HF, which is an even larger trial, so over double the size of Castle AF with 800 patients with heart failure and reduced ejection fraction. So really exciting times to establish the role of catheter ablation for AF and heart failure. So now turning to PCI for heart failure. This is again a really exciting area. We can see on the left-hand side of the screen coronary arteries which are heavily diseased. And on the right-hand side, after extensive stenting, there's certainly an apparent improvement in certainly the coronary blood flow. But in the longer term, how does PCI balance with medical therapy? Of course, if we put 8 or 9 stents in people's coronary arteries, there is some risk for the procedure. And what are the implications in the longer term for having so many stents in your coronary arteries? Is it beneficial with improved myocardial perfusion and maybe improved outcomes? Or do these people have stent thrombosis, in-stent restenosis, and do they have problems with worsening renal function, with worsening anemia on antiplatelet therapy? How do these pros and cons of PCI and heart failure balance? So I'm delighted to say we've completed enrollment of a trial in the UK called the Revived trial. We have randomized 700 patients with ejection fractions less than 35%, with really very extensive coronary disease. And we've randomized the patients to PCI or medical therapy with a primary endpoint of all-cause mortality or heart failure hospitalization. And we're going to present these data next year at the ESC. So I think this is a really interesting trial. Does PCI benefit people with heart failure? So now turning away to microclip for heart failure. We've heard a lot about this over the last few years. And all of you will be very aware of the different results of the MITRA-FR trial and the COAPT trial. So MITRA-FR, the French trial, didn't suggest any benefit, and COAPT suggested a major benefit with a 47% reduction in heart failure hospitalizations. So there was obviously differences in the patient populations, difference in the procedural outcomes, and many difference even in the assessment of mitral incompetence, and also the ejection fractions in these trials. So really major differences between these trials. So what we're looking for is more randomized evidence. So here we're completing a trial called ReShape-2 with 420 patients with low ejection fraction, again randomized in a similar way to COAPT and MITRA-FR. So we'll have more data in this area as well to establish exactly which patients benefit and how often we should refer our patients with heart failure and mitral incompetence for microclip therapy. I would love to talk about all these different mechanisms of trying to improve mitral and tricuspid regurgitation. And I'm sure you're all aware that there's a huge amount of different devices, including annuloplasty devices or coaptation enhancement devices, which are really exciting, as well as valve replacements, which are percutaneously available. But what I'm keen to say about this is these are all heart failure therapies and should be assessed robustly in randomized controlled trials, which are blinded and also sham controlled. So there's lots of different investigations and different data emerging with respect to the role of these things in heart failure. Again, I don't have time to talk about too many things, but CardioMEMS has been interesting for many of us over the last few years, with the encouraging data from the relatively small CHAMPION trial, suggesting the CardioMEMS device as a pulmonary artery pressure monitor may reduce heart failure hospitalizations. So there's also a trial called GUIDE-HF, which is ongoing at the moment, which is randomizing 1,000 people to CardioMEMS or continued medical therapy. There's lots and lots of other devices available. This is a Vigo device, which is a counterpulsation device attached to the thoracic aorta. So really exciting technology. And also NewPulse, which is implanting in chronic ambulatory heart failure patients a balloon pump via the subclavian artery, the axillary artery. So really, really exciting to see whether this has a role in heart failure. So turning away from device to drug therapy, what's happening in drug therapy? So we're all aware that the AFFIRM trial presented at the AHA very recently showed a borderline benefit in heart failure hospitalizations with intravenous iron therapy. So we're delighted to say there's 3 ongoing trials, again, which are going well and will report relatively soon. We have a UK trial called Ironman with 1,300 patients, so slightly bigger than AFFIRM HF, with ejection fractions less than 45%. You'll see all of these trials have very sensible primary outcomes, cardiovascular death and heart failure hospitalization. We have FAIR-HF2, which is a German trial, very similar design as well. But probably the most interesting trial is the US trial, which is by far the biggest, run by the NIH, with over 3,000 patients randomized intravenous iron or placebo. So over the next few years, we're going to see 3 more large outcome trials to tell us which of our patients should receive intravenous iron for heart failure. I know you've talked about SGLT2 inhibitors a lot in the meeting so far, and I'm sure you're very aware of these 2 large outcome trials, which we'll publish next year, looking at the role of SGLT2 inhibitors in heart failure with preserved ejection fraction. So we've got Emperor Preserved with empagliflozin with just under 6,000 patients, and we have Deliver with dapagliflozin with just over 6,000 patients. So again, within the year, we will be able to discuss the role of SGLT2 inhibitors in patients with HFpEF. So I'm really keen to talk about the post-myocardial infarction trials, which are also ongoing. The first of these, which is due to report very soon, will finish follow-up in January, just next month, and that's a Paradise MI trial, looking at the role of sacubitril valsartan compared to ramipril in patients with myocardial infarction. And of course, these are not all-comer myocardial infarctions, but those are complicated by heart failure or left ventricular dysfunction. So again, a large trial, 5,700 patients in this trial, with a primary outcome of cardiovascular death or heart failure, hospitalization, or outpatient heart failure. And for those football fanatics, this trial is named after Celtic Park, which is a Glasgow football club, which is also called Paradise. So also in the myocardial infarction area, there are 2 ongoing trials of SGLT2 inhibitors. Again, very similar populations to Paradise MI, so large myocardial infarctions complicated by left ventricular dysfunction or heart failure. One of the very good ones is Impact MI with 3,300 patients, and this is an empagliflozin trial. And again, you see the primary endpoint is heart failure hospitalization or all-cause death. DAPA MI is a very large trial. They're not quite as big myocardial infarctions. You can't get in with congestion, but these are people with ejection fractions less than 50% or with Q waves. And again, this is a dapagliflozin trial. So looking at SGLT2 inhibition in other populations, hospitalized heart failure has caused a lot of interest. And I'm sure you've reviewed the results of the Soloist worsening heart failure trial, which was again presented at the American Heart Association. And although it was terminated early due to lack of funding or withdrawal of funding, it did show benefit. But we've got a large ongoing trial of dapagliflozin in hospitalized heart failure patients, again, which will report relatively soon with a primary endpoint at 60 days only of cardiovascular death or worsening heart failure. So it's also exciting time for oral diuretics as well as subcutaneous diuretics. And there's this very large trial which is ongoing, looking at how good toracimide is compared to furosemide. So 6,000 patients were hospitalized with heart failure with reduced ejection fraction and high BNPs. I'm looking to see if toracimide can reduce all-cause mortality. And I'm sure you're all aware of the potential benefits of toracimide over furosemide. So over the years, heart failure doctors have seen a lot of mineralocorticoid receptor antagonists. And we know clearly from the two large trials, RAILS and EMPhASIS, of the benefits in heart failure with reduced ejection fraction. But the TopCat trial was a disappointment, as it didn't quite meet the primary endpoint, partly because of the various issues with the trial we know about, such as patients in Russia and Georgia not receiving the therapy in the way that the trialists had expected. So there are various ongoing MRA trials in HFpEF. This is a trial between Sweden and the US, enrolling 3,200 patients with HFpEF and randomizing to spironolactone or placebo, and again with a primary endpoint of cardiovascular death and heart failure hospitalization. So really excitingly is this drug called finerenone, which is an MRA which has been studied for around 5 years. And we've heard already in the Fidelio trial in patients with chronic kidney disease, this drug is actually beneficial. So an MRA that is beneficial in renal and cardiovascular terms in patients with chronic kidney disease. So we've realized that this drug might be useful in heart failure. And there's a very large international trial which is well underway called FINEARTS. This is a trial of 5,500 patients with heart failure and preserved ejection fractions. So ejection fractions above or equal to 40 and high BNPs, randomizing to finerenone or placebo with a primary outcome of cardiovascular death or worsening heart failure. So we're hoping to learn from the TopCat trial, and obviously this is a more attractive molecule, and I'm pretty confident this trial will be positive when it's published in 2 or 3 years' time. So I did want to turn to GLP-1 receptor agonists, which we've heard a lot about in patients with diabetes over the years. These drugs reduce major adverse cardiovascular events in patients with diabetes. But we've realized that these drugs have potential benefits in populations such as heart failure with preserved ejection fraction. If you use them at obesity doses, you can allow the patient to lose up to 15% of their body weight. So that can be 15 or 20 kilograms. They lower blood pressure, they've got anti-atherosclerotic effects, beneficial renal effects, and they also might lower blood glucose in a way that was helpful to the myocardium if you're a believer in diabetic cardiomyopathy. So there's ongoing 2 trials of obese HFpEF with and without diabetes with semaglutide. So again, really exciting times for HFpEF. So potassium binders, again, emerging therapies. This is the largest trial which is ongoing, looking at potassium binders in heart failure with reduced ejection fraction. This is a trial called Diamond with butyromer, and it enrolls patients of 2,400 patients who have had hyperkalemia over the last 12 months and randomizes them to butyromer or medical therapy, and again, looking to reduce cardiovascular death or cardiovascular hospitalization. So in that short talk, I'm sorry I couldn't cover all of the range of exciting device and drug therapies, but it's an incredibly exciting time for heart failure. We're due to see lots more evidence over the next 2 or 3 years. And I think we just need to emphasize that heart failure is a condition which has major mortality and morbidity, and we really need to take it seriously and manage heart failure within passionate and interested heart failure teams. And at that point, I want to thank you very much for your attention.
Thank you, Dr. Peter. Actually, a lot of data, and it seems that heart failure will consume a lot of our efforts in studying these data. Actually, I have two questions. One about the ablation of atrial fibrillation in heart failure and the recurrence rate. Is it like the success and the recurrence rate after ablation? How to maintain. The second question is about the. Let us answer the first question shortly first.
Yes, so the success rate of ablation in heart failure is not as high as we'd hope. So after the first procedure, it's around 50%. And in all of these trials, we factored in the possibility of the second procedure, which brings the numbers up to around 70%. Obviously, that varies depending on the cardiac substrate and the patient. So we can see lower or higher numbers. The numbers I've just quoted are in heart failure with reduced ejection fraction. In preserved ejection fraction, it's also different. But we have noted over the years that there are some factors from a cardiac perspective which can tell us how likely we are to be successful. And those certainly include things like the left atrial volume or the amount of scar we see. So there are many different factors which predict the success rates. If we look at the Castle AF study, in the longer term, comparing AF ablation with continued medical therapy, after the end of follow-up, the difference in the AF prevalence was only about 20%, remarkably, which is amazing, given they reported a mortality reduction of 47%.
Okay, the second question is about revascularization in heart failure. Whether this is regardless of viability, whatever the viability is, or there is some condition?
Yes, so that's a very controversial issue. I was involved in the STITCH trial, which again, I'm sure that everybody listening has passionate opinions about how valid the results of viability were in STITCH. But I think it's fair to say that with surgical revascularization, we really don't know what the role of viability is. So for our PCI trial, we did mandate that the area which was going to receive stents should be viable, and we had various different criteria for what viability might represent viability. So our trial is not of people with thin, scarred, akinetic anterior walls. These are people who look like they do have viable myocardium. And again, that's controversial because, as you say, how do you define viability? What's the role of it? That's an area in cardiology which is in desperate need of major research.
Mark, thank you very much. But regarding the heart failure preserved ejection fraction, actually, no drug till now has the leader for this type. What is your opinion about the failure rate of any drug? I mean, you're starting again to attack by new drugs, SGLT2 drugs 1 and 2, trying with ARNI but failed, trying again with the mineralocorticoids. Do you think this is, I know that Lars is going to speak about heart failure preserved and the phenotypes in the next lecture, but do you think that this is, we don't know the phenotypes of preserved ejection fraction, that's why we don't know the treatment? Because already all drugs coming with the heart failure was reduced has a great success, but not with preserved ejection.
Yeah, I'm sorry, I couldn't hear that. I'm sorry. I don't know if anybody else could maybe summarize
I'm sorry.
the question. I couldn't hear it.
What is the failure, what is the cause of failure of drugs treating the heart failure with preserved ejection fraction? You know, the older drugs for the heart failure with reduced ejection fraction are successful, even the new drug SGLT2. But till now, we don't have the actual treatment of heart failure preserved. What is the cause? Is it the phenotypes? We don't know the heart failure preserved ejection fraction till now?
I'm sorry. Mahmoud, did you know what the question was?
No, I think there's a problem with the sound system. I can't hear your words.
Do you hear me now?
Okay? So there's some problem with the
Sorry, you hear me now?
Thing.
Do you hear me?
I'm sorry, it's very, just I can't hear the individual.
Yeah. يمكن ابعد شويه عن الميكروفون يا محمد، يمكن الصوت بيأكوز، واتكلم بالراحه وكده ما تقطعليش صوتك.
I could hear the first speaker very clearly, so maybe somebody could summarize the question.
طب خد الميكروفون بتاع اشرف رضا مثلا.
خدت الميكروفون. What is the cause of failure?
ده احسن. Yes, okay, okay.
What is the cause of failure of any drug treating the heart failure with preserved ejection fraction?
Okay, yeah, so I think that's a very big question, and if I'm talking obviously with Lars Lund listening, and he's done a lot of work in this area. So Lars and many colleagues have looked at drug therapies in people with ejection fractions above 40%. And there's a very consistent message that most of the drugs that are effective in heart failure with reduced ejection fraction, with ejection fractions below 40%, are also effective up to an ejection fraction somewhere between 50 and 57%. So I think that applies to ACE inhibitors, to beta blockers and sinus rhythm, to sacubitril/valsartan. So I think we do know these drugs are effective. The problem is these patients were not enrolled in dedicated trials of heart failure with preserved ejection fraction. So I think it's difficult to recommend giving people with heart failure and ejection fraction between 40 and 57%, all of these therapies. But I do think that the other problem with heart failure with preserved ejection fraction is it's a very heterogeneous group. So there's lots of different types of patients in heart failure with preserved ejection fraction that might benefit from different therapies. So I'm hoping over the years we target different therapies to subgroups of people within the heart failure with preserved ejection fraction group. I do think, though, that drugs like SGLT2 inhibitors are likely to be beneficial, at least to some extent, in people with ejection fractions above 40%. So I think the trials DELIVER and Emperor Preserve will be positive, but how positive they are, I'm not sure. Whether that will be a reduction in heart failure hospitalizations, an improvement in quality of life, an improvement in kidney function, but I'm not sure they will reduce mortality. But I don't know I can't predict the results of these trials. But I think we need to be quite clever with heart failure with preserved ejection fraction and think what's wrong with the individual patients.
Thank you, Professor Mark. You talking us in deeper and deeper about the drugs and device, and I like so much the delivering system of furosemide subcutaneous is very challenging. Yes, thank you very much for your excellent talk.